Hi, thank you for giving me the opportunity to speak today. I will be talking to you about combining PARP and FEN1 exo-1 inhibition in triple-negative breast cancer. My name is Saima Hassan. I'm a surgical oncologist, associate professor, and the Scotiabank Chair in the Diagnosis and Treatment of Breast Cancer at the University of Montreal, Quebec, Canada. First, I will be talking to you about the clinical background of PARP inhibitors. Then I will be discussing the genomic prediction of response to PARP inhibition, and then some of the most recent work on combination of PARP inhibitors and FEN1 inhibition and future directions. Triple-negative breast cancer comprises 15 to 20% of all breast cancers, lacks overexpression of estrogen receptor, progesterone receptor, and HER2. It is more frequent in younger patients, patients of Black and Hispanic origin, and is associated with BRCA1 mutation. The rate of recurrence is much higher in the first 3 years post-diagnosis, and the patients tend to have a shorter overall survival. Current treatment options for triple-negative breast cancer. For patients with early TNBC, patients often receive 4 types of chemotherapy, including anthracyclines, cyclophosphamide, taxane, carboplatin, in combination with an immunotherapeutic, pembrolizumab. If there's residual disease, patients continue to receive pembrolizumab in combination with either capecitabine if they are BRCA wild type or olaparib if they are BRCA mutant. In the adjuvant setting, patients receive 3 types of chemotherapy, including anthracycline, cyclophosphamide, taxane, plus or minus olaparib. In the metastatic setting, patients receive often single-agent chemotherapy, including taxanes or eribulin or capecitabine. However, targeted therapeutics are emerging more in this setting, including pembrolizumab for PD-L1 positive disease, or olaparib or talazoparib if they're BRCA mutant. PARP inhibitors have 2 main mechanisms of action, synthetic lethality and PARP DNA trapping. The concept or the premise of synthetic lethality is that if you target gene A, the cell survives. If you target gene B, the cell also survives. But if you target gene A or B, i.e. BRCA1 or 2 or PARP1 or 2, this leads into cell death or synthetic lethality. In particular, when you have a single strand break, the PARP enzyme comes and binds to this area. However, when you have a PARP inhibitor, it prevents the release of the PARP enzyme. This leads to single strand breaks, and this then leads to the formation of double strand breaks. In the context of BRCA wild type tumors, there is sister chromatid exchange, and that leads to cell survival. In the context of BRCA mutant tumors, there's complex rearrangements, G2M arrest, and cell death. PARP DNA trapping consists of the PARP1 that traps on DNA, and the PARP inhibitor prevents this PARP from being released. This leads to DNA damage and cell death. This mechanism is reminiscent of the conversion of topoisomerase I into a poison by a topoisomerase I inhibitor. There are several PARP inhibitors that have been investigated in preclinically and clinically. The following is a list of PARP inhibitors from left to right based on their potency, and their potency is based on their ability to have increased PARP DNA trapping ability. So the most potent is talazoparib, followed by niraparib, followed by rucaparib, which is similar to olaparib, and then finally veliparib. Over the past 12 years, the FDA has approved PARP inhibitors for various indications, including for ovarian cancer, breast cancer, pancreatic cancer, and prostate cancer for BRCA mutant and BRCA wild type contexts. A similar trend was observed for Health Canada since 2016. However, a significant landmark trial that occurred in metastatic breast cancer for amongst BRCA mutant breast cancer patients is the Olympiad trial. Here, olaparib demonstrated an objective response rate of almost 60%, with an improved progression-free survival of 7 months in comparison to 4.2 months amongst patients who had received the treatment of physician's choice, including single-agent chemotherapy. A similar response was identified amongst talazoparib with an objective response rate of approximately 63% and an improvement in progression-free survival of 8.6 months in comparison to 5.6 months. In a subgroup analysis of this study, amongst the patients who did not receive any prior chemotherapy, patients who received olaparib demonstrated an important improvement in median overall survival of approximately 23 months, and this was significant difference compared to patients who received treatment of physician's choice, where the median overall survival was only approximately 15 months. However, such difference in OS was not identified amongst patients who received prior chemotherapy in metastatic breast cancer, i.e., those that received olaparib in the second or third line. In the adjuvant setting, the Olympia trial was a randomized controlled trial in which patients received either olaparib or placebo for 1 year. There were 1,836 patients, and at 6 years, invasive disease-free survival was a difference of 9.4%. The distant disease-free survival at 6 years was 7.8%, and the overall survival at 6 years was 4.4%, which led to an important change in practice for BRCA mutant patients. In the neoadjuvant setting, there were a couple of interesting trials. Talazoparib was administered for 6 months as preoperative treatment. Adjuvant treatment was administered at physician's discretion. And at a pilot study with N equals 20, the PCR was a remarkable 53%. The NeoTALA study, a phase 2 study in which there were 112 patients, the PCR was approximately 46 to 49%. In the neoadjuvant setting for TNBC patients, there were 2 interesting studies. The PETROMAC trial was a phase 2 study in which unselected cohort of patients were given olaparib for up to 10 weeks prior to adjuvant therapy. Although N equals 32, the objective response rate was 56.3%. Rucaparib was also given in another phase 2 study in which primary TNBC or BRCA2 mutant patients were present. Rucaparib was given for 12 to 14 days. Although N equals 43, there were 19 patients assessed for ctDNA. There was greater than 75% decline in ctDNA in 58% of patients. In summary, the clinical efficacy of PARP inhibition has been demonstrated in breast cancer amongst BRCA mutant patients, but could there also be a role amongst a larger subset of TNBC patients? To better understand this, I'm presenting 2 main objectives. First is the genomic prediction of response to PARP inhibitors in TNBC, and the second is the use of PARP inhibition in combination with FEN1 or XO1 inhibition. To address the first objective, I will discuss the potential utility of PARP inhibitors using various biomarkers, either genomic or through imaging or gene expression signatures. However, I will focus on the genomic predictors. Copy number-based genomic scar assays. What are these assays? These are SNP array-based signatures of chromosomal instability that quantitate a distinct type of genomic scar likely to cause improper DNA repair. On the left, we see NTAI, which is the number of subtelomeric regions with allelic imbalance. In the middle panel are LST, or large-scale transitions, the number of chromosomal breaks between adjacent regions of at least 10 megabases. And finally, on the right is HRD-LOH, which is the number of LOH regions that are larger than 15 megabases. There are 2 commercially available tests. The first is Genomic Instability Score, or Homologous Recombination Deficiency, or HRD score, from MyChoice HRD test, which is derived from the unweighted sum of NTAI, LST, and LOH. The HRD-LOH score, or Foundation Focus Companion Diagnostic BRCA, is the fraction of subchromosomal segments excluding chromosome 17, since LOH was observed in almost all samples of this chromosome in the discovery cohort. The evidence for HRD biomarkers in breast cancer is a bit mixed. So the HRD score has been shown to be predictive of platinum response in some neoadjuvant TNBC studies. However, it failed to predict carboplatin or olaparib response in metastatic breast cancer. The LOH score showed association with platinum response in some DNBC cohorts, but it was not predictive in the Olympiad study, and different LOH cutoffs have been used across studies. HR-Detect uses whole genome sequencing to identify HR-deficient TNBC and was associated with platinum benefit and survival. However, the study is retrospective based on a smaller number of patients. BRCA1 nest signature identifies BRCA1-like tumors beyond the BRCA mutations, but limited clinical validation has been identified. So overall, clinical utility remains challenging due to heterogeneous patient populations, lack of standard cutoff and thresholds, and there has not been any prospective validation. We have previously identified a 63 gene signature using preclinical data. Using a panel of TNBC breast cancer cell lines, we looked at the DNA damage response and categorized cell lines as sensitive or resistant based on their DNA damage response and based on the combined response of 3 different PARP inhibitors. We then performed gene association analysis, gene set enrichment analysis, and found a number of pathways involved, including but not limited to DNA repair, base excision repair, DNA damage bypass, mismatch repair, Fanconi anemia pathway. This gene signature was found to be associated with 87% accuracy in predicting response in patient-derived xenografts, and was identified in 45% of TNBC patients. The concept of this signature is that with higher expression, it was associated with PARP inhibitor resistance. Clinically promising therapeutic targets have been identified from this gene signature, including CHEK1, USP1, ATM, and WEE1. Now I will proceed to the second objective of my presentation, which is the use of PARP inhibitors in combination with FEN1 exo-1 inhibition. From the 63 gene signature, we identified 6 potential genes that could be knocked down and treated with talazoparib. The combination of the effects were measured via flow cytometry to evaluate DNA damage with gamma H2AX expression and the induction of apoptosis. There was a significant induction of DNA damage with the combination in comparison to talazoparib alone for 5 out of the 6 genes. However, there was a significantly enhanced impact upon cell death, and when we used SI-FEN1 or SI-XO1, leading to the selection of these targets. FEN1 is responsible for removing 5' single-stranded flap generated during long patch gap filling and single-strand break repair, a major part of base excision repair. A major role in RNA primer removal during Okazaki fragment maturation of the lagging strand during DNA replication. As we can see in the figure on the right, FEN1 is overexpressed largely in basal breast cancer, which is similar to triple-negative breast cancer, and luminal Bs. Increased expression of FEN1 was associated with poor prognosis amongst breast cancer patients. Commercially available inhibitor targets FEN1 exo-1, and that name of this inhibitor is called LNT1. So the rationale for combining FEN1 inhibitor and PARP inhibitor are twofold. First, S-phase PAR levels are dependent on DNA replication stress. Altering FEN1 expression increases S-phase PAR by more than 10-fold. Human cells lacking PARP1 are hypersensitive to FEN1 perturbation. If we look at the panel on the left, in the context of BRCA1 deficiency, you can either have a double-strand break, which leads to end resection, or single-strand break. This leads to the recruitment of PARP or polymerase theta, and it also leads to gap filling or 5' flap processing with FEN1, and this leads to cell survival. However, in the context of BRCA1 and FEN1 deficiency, when you have the recruitment of PARP1 and pol theta, we're unable to further and pursue the 5' flap processing, and this leads to replication stress, genomic instability, and cell death. Therefore, our hypothesis is that targeting FEN1 and PARP1/2 can lead to synergistic effect in triple-negative breast cancers. Our aims are to better understand the role of targeting FEN1 and in PARP inhibitor-resistant cell lines, and to measure the impacts of the combination of DNA damage, apoptosis, and DNA replication. We also aim to identify genetic determinants of PARPi resistance. So the first step was to derive PARPi-resistant cells. PARPi-sensitive, BRCA2 mutant, HCC 1395 cells were exposed to increasing concentrations of talazoparib or olaparib. Stable resistance was confirmed by passaging 5 times in the absence of PARPi and freeze-thaw cycle. We then performed a chemosensitivity assay where cells were seeded for 10 days and imaged using a high-content imager by Perkin-Elmer called Operetta. Here we found a spectrum of response with talazoparib, and the majority of responses fell in the nanomolar range. However, LNT1, there was a narrower range of sensitivity in the low micromolar range, and the spectrum of sensitivity was different from talazoparib. We found that 70% of the TNBC cell lines demonstrated synergy or an additive effect. BT549, HCC 1395 with acquired resistance to olaparib or talazoparib, and also the additive effects were identified with MDMB231, HCC 1806, and MX1. We also derived a TNBC organoid from a xenograft mouse model. This was from HCC 1806, and the organoid itself demonstrated an IC50 of 0.11 micromolar. This organoid was also resistant to LNT1 with an IC50 of 12.5 micromolars. However, the combination showed that it had a combination index value of 0.80, which demonstrates or illustrates synergy. And then we evaluated the treatment effects on DNA damage. On the top, we have a highly synergistic cell line, and we saw that the DNA damage was quite significant with the combination, and in particular in comparison to LNT1 and talazoparib alone. We also saw a similar trend with MDMB231. However, of note, the DNA damage induced by gamma H2X by talazoparib itself was significantly high. Such a trend was evident across different time points, including 24, 48, and 72 hours. We also performed the DNA fork speed assay, or DNA fiber assay, to evaluate DNA fork speed. Here we found that talazoparib does increase fork speed, similar to what we previously reported. However, the combination demonstrated a much higher increase in fork speed, a delta of 47% or 31% amongst the synergistic cell lines, and this was much higher than those that demonstrated an additive effect, which was approximately 24%. Suggestive that this may play an important role in mediating synergy. We then performed RNA-seq analysis of the untreated cell lines. We first compared those cell lines that became sensitive upon addition of LNT1, but were inherently resistant, and then we compared it with that cell line that was resistant with the combination and with PARP alone. This is the heat map of all these cell lines. And interestingly, such comparison showed that the top most upregulated pathway was that of ribosomes. The second pathway is that of mismatch repair. And then when we wanted to evaluate what were the genetic determinants of acquired PARPi resistance. We found that there were so we compared the acquired resistant cell lines of HCC 1395 in comparison to the HCC 1395 parental. Once again, the topmost pathway is the ribosomal pathway. And so FEN1 is a potential target for combination therapy with PARP inhibition. The combination of FEN1 inhibition with PARPi is additive or synergistic in the majority of TNB cell lines and an organoid model. The greatest synergy was observed in a BRCA2 mutant cell line with acquired PARPi resistance. DNA damage and DNA replication speeds are increased in response to LNT1 and PARP inhibition, and ribosomal pathways are upregulated in PARPi resistance. This is similar to previous reports in mouse mammary cell lines and tumors. Amongst future directions, we'd like to evaluate newer small molecule inhibitors of FEN1 and to evaluate the role of FEN1 knockdown in the inhibition of ribosome biogenesis. I'd like to acknowledge my current and previous lab members, collaborators, and all my funding support. Thank you for your attention.